All right, let's do chapter 5. And this is when we start getting into cellular activity of the heart. I just posted a video called Understanding or titled Understanding Action Potential, and skip to like the 8-minute 45 or 8-minute 49 mark to actually start the video. And you can skip over some of just the conversation of me in the class I was teaching. But that video is me working on a big smart board and trying to draw this out to kind of make sense. So, all right, let's go over this one. So depolarization, and the reason you should watch that video first is because these probably won't make any sense until you see what's going on at the cellular level, and I draw that out in that video. So depolarization, the electrical gradient between inside of the cell and outside of the cell are different. And like the video will show that when sodium rushes into the cell depolarizes. It becomes more positive inside of the cell than outside of the cell, and it basically fires off an impulse. That's depolarization. Repolarization is when adenosine triphosphate, which is called the active transport pump or sodium potassium pump, kicks in. The sodium does not want to leave the cell because there's a higher concentration of sodium outside of the cell than inside of the cell. And there's more potassium inside of the cell than outside. So they don't want to go from high concentration. They want to go from high concentration to low concentration. They do not want to go from low concentration to high concentration. So they have to be pumped. They need a pump to facilitate that. And that is the repolarization phase. Once again, it's explained in that video. Electrodes are just little foam pads. They have a little strip of metal with some conductive gel, and we're able to attach lead wires to those electrodes. Those electrodes are what's going to set on the skin and detect the electrical movement of the electrical movement of the electricity through the heart. In the heart, there's two types of specialized cells. You have electrical cells and you have mechanical cells. And then they have properties of their own. The electrical cells can fire off their own impulse. They can generate their own impulse. It's called automaticity. So they can do it automatically. And that's what that video explains. And then they're also excitable. So they respond to the cells that are next to them. So when a cell fires off next to it, it then causes that cell to depolarize. And it goes on down the line. Those electrical cells will stimulate the mechanical cells, which is the muscle cells, and the muscle cells will contract. So the specialized properties of the mechanical cells or the muscles is the force of contraction. So how well the pump works. Leads are the cables that just connect the cardiac monitor to the electrode, and it will show up on our paper as ECG or EKG tracing. And the tracing is basically our rhythm strip. And you're going to learn to read these and what all the waveforms mean. An electrocardiogram is just a collection of those strips. The electrical cells can be firing off, and you might not have mechanical cells that are responding to them. So you can have something called pulseless electrical activity, where the cells of the heart are firing off, but the mechanical cells are not pumping. So just remember these basic parts. The cells of the heart are able to create and conduct electrical signals, and then those hopefully will stimulate the heart muscle to contract and pump the blood. And you'll see that we have an electrical conduction system in the heart. Now, if you was to dissect a pig heart or whatever, you would not see the difference between mechanical cells and electrical cells. So all the illustrations will show it as like maybe yellow or a different color than the heart muscle cells, but they all look alike. So you can't tell just by looking at it what they are. Depolarization, repolarization. That depolarization is when the cell becomes more positive than negative. And then the repolarization is when the cell gets repolarized. It pumps out those sodium ions, and it pumps in, returns the potassium ions. During depolarization, we hope that it causes the mechanical cells to contract and therefore pump blood. But you have to check a pulse, right? So you almost always hear me say, well, does it mean anything when we're reading strips? Because we always want to treat the patient, not the monitor. And these patterns, they'll happen in continuous cycles. And anyway, you're going to learn how to read those. The way that it fires off the sequence, it makes the top of the heart, which is the atria. The atriums fire, they fire off first, they depolarize first, and the atriums will contract. That blood that was in the atriums gets ejected down into the ventricles. We have what's sometimes called ventricular top off or filling, and then the impulse will go down and then stimulate the ventricles to pump the blood. Let's see, we've already mentioned that the electrodes are connected to the machine. The lead wires are connected to the electrodes, and those set on the patient's skin. And the different views are created by where the electrodes are placed on the skin. And once we get back in class, I'll draw this out on the board, so hopefully it'll make sense. And there is a difference between the words lead and electrode. The lead has a view. The lead is like a camera. It's like a positive electrode that looks wherever the negative electrode is. So the lead is what is looking at the heart muscle. The electrode is where the little foam pad sits on the skin. And once again, just to say, because it's up here, the EKG doesn't tell you if the heart's pumping blood. It only tells you that the electrical system is working. So we need to make sure that the mechanical cells are actually working also. And we'll do that by checking a pulse, checking a blood pressure, and looking at our patient. Voltage is just a difference in electrical charge. So most of these EKG machines, like the ones in the hospital, they're going to have a screen. They'll have like a keyboard and a printer. Some of them have a stylus so you can write on the screen. It's usually wheeled around, and it's usually kept in the hallway or plugged in a little storage area. You'll have 10 lead wires that gives you 12 views of the heart, and I'll show you why whenever we get in class. There's actually only 3 electrodes that have to be placed in anatomical positions, and then all the other leads or electrodes are placed around those 3. And those wires are going to be either little clamps or snips that are going to connect to the electrodes. Telemetry, that's just the technology they use to monitor the heart rhythm. Often used in the emergency room or hospital. You'll see where the patient has a cardiac monitor leads on them, and then in another room, you'll see people looking at the screen. So they're able to monitor that patient without being in the room with them. Ambulatory monitoring. Ambulatory just means they can walk. So these can be placed on the person. They can leave the doctor's office or the urgent care or get discharged from the hospital. A lot of them are called Holter monitors, and not halter, but Holter. And the patient wears them. It could be a 24, a 48, or 72-hour study. Some of these are triggered. They have event monitors where they can trigger them when there's an event, like they feel have rapid heart rate or shortness of breath. They can event monitor it. And a lot of times these event monitors can be interrogated either over the phone or they can be transmitted or recorded on an app, and it can be monitored by the cardiologist or doctor's office. So the 12-lead EKG, this is the most common type of electrocardiogram. And of course, that's the 10 cables that give you 12 lead views of the heart. Basically, with the 12 lead, you're really just looking at the left ventricle of the heart. And I'll show you when we get in class what that means and why it's important. A stress test, if someone's having, like, I think we mentioned it in class, like, let's say I go down to the mailbox and I have chest pain and I sit down and rest and the chest pain goes away. That would be stable angina. That usually generates a phone call to a doctor's office or a visit to the ER. And the doctor there may order, send you off to a cardiologist office, or eventually they could order a stress test. And they could either do one where you get on a treadmill, an exercise stress test, or they could do one where they inject you with medication and it'd be more of a chemical stress test. So you have to be familiar with continuous monitoring. That's used in emergency care settings. Those are the patients that are in there for a long period of time. They'll have the monitor on them in another room. Someone's monitoring their telemetry. And then just telemetry is used in large facilities. They'll have all that stuff come into multiple monitors in one room to where it can be monitored. So they're called telepacks, and they can come into the room, place a telepack, and that will send the signal back for monitoring. Those Holter or ambulatory monitors, those are going to gather the patient's rhythm over a period of 24, 48, or 72 hours. They'll send them home wearing those. I think now they even shower in them, but I know for a long time you couldn't. But those patients will then either return the machine or they'll have some way of interrogating the information off of it. And we already talked about 12 leads and stress test. A rhythm strip is what we call their ECG recording. So we'll get two types of strips. Generally speaking, we'll have a rate and rhythm. And so rate and rhythm strip, and that's just the limb leads, usually lead 2. And it says 12 seconds, but if you get a 10 to 12 second strip, that's great. We can tell the underlying rhythm off of a rhythm strip. Those 12 leads are really to just determine whether or not the patient's having a heart attack, called a STEMI. That's we'll go over that because we're going to do a 12 lead class for you guys too. The limb leads literally go out on the limbs, and that's leads 1, 2, and 3. Until I get to drawing on the board, it might not make a lot of sense. It uses terms like bipolar leads and unipolar leads. Really just remember that each lead has one and only one positive electrode. So, but the limb leads are bipolar leads. So they share one lead and it changes where the negative electrode's looking, or it changes the location of the negative electrode. So therefore changing the view of what it's looking at. Einthoven's triangle. This is imaginary triangle, or it's triangulating the electrical impulse in the body. We're put the long time ago, Einthoven discovered that if you put like one foot, your left foot in a bucket of saline and your hands in buckets of saline water, that he could detect electrical movement, electrical impulses. And Einthoven so basically created the first ECG machine so they could monitor the movement of electricity through the heart. Augmented limb leads, that's AVR, AVL, and AVF. AV stands for augmented voltage, and then it's right, left, and inferior. These are also on the same vertical plane of the heart as limb leads, and the augmented limb leads are basically a computer using a microprocessor to calculate what the lead would look like if it had an extra electrode placed in those areas. And I'll draw them on the board when we get in class so you can see exactly where the leads are. Unipolar leads. Oh, so let me go back just a little bit. The AVR, AVL, and AVF, leads 1, leads 2, and lead 3, all of those have amplified voltage. So the cardiac monitor itself will actually increase those voltages for us. With the unipolar leads, it doesn't do that. It's what you see is what you get, and they only have one positive electrode each. And your unipolar leads are also the precordial leads, That's V1, V2, V3, V4, V5, and V6. These are also just commonly referred as the chest leads. So you might hear chest leads or precordial leads. These leads are actually looking at the heart in a transverse or horizontal plane. It's almost like if you held a hula hoop out in front of you with GoPro cameras on it that are looking at your heart. Wilson Central Terminal. This is just an electrical neutral point in that Einthoven's triangle. That's just one of those things they like to throw in test to make sure you've heard of it before. This is an actual 12 lead tracing. So the top 3 rows are the 12 lead. So as you look at these top 3 rows, kind of start looking to the right, you'll see there's 4 columns. So there's 3 rows and 4 columns. I don't know if you might see my mouse or not, but here's lead 1. This is a 2.5 second strip. And then AVR, that's 2.5 seconds. So that makes a total of 5 seconds. V1, another 2.5 seconds, takes us to 7.5 seconds. And V4, that takes it up to 10 seconds. So of this 12 lead, if it won't let me draw it, for this 12 lead, see if it'll let me draw it like this. There we go. This is the normal 12 lead. Oh, I just hit my keyboard. That's the normal 12 lead view. There's 3 columns. Here, oh my goodness. There's a column, there's a column, and there's a column. And then you have 3 rows. 1, 2, 3. So this is the 12 lead, and down at the bottom, this long strip is called the rhythm strip, the rate and rhythm. So if I'm trying to determine the rate and rhythm, that's where I look. And if I'm trying to determine whether or not the patient's having a STEMI, I look up here. So that's our 12 lead. Everything on, see, everything from back this way, here to here, these are all augmented voltage limb leads. So these are our limb leads, and limb literally means they go out on the limbs. So the arms and the legs, and these are augmented voltage. So everything on this side of the strip is bipolar leads, and everything on the right side of the strip this way are your chest leads or precordial leads, you could say that, and they're unipolar. And then down here, this is just lead 2, which is the same lead as this one right here. But lead 2 has the very best view of the heart. So that's why we or the left ventricle, I should say, not the heart. And we get our rate and rhythm from lead 2. These are all the things that we were talking about. These are limb leads, and that's Einthoven's triangle. And what you'll notice is that all of these leads, that's 2, 3 and AVF anyway, they share a positive lead down here in the, so 2, 3 and AVF are in this leg, and then 1 and AVL are out here on this hand. And they're able to share this lead. So if you want to look at lead 2, it'll change the negative electrode to here, so the eyeball looks this way. If we want to look at lead 1, would just look up this way. And if we want to look across here for lead 3, it actually will explain it on all these different slides. So here, which I can't really tell, this is supposed to be, I think, lead 1 looking across. The positive electrode here is the negative one. So that positive electrode, just think of it like an eyeball. That's not going to be a well-drawn eyeball, but hopefully you'll get the idea. So the eyeball is only going to look at the negative electrode. So in this case, it's looking across the heart. Lead 2, here's our eyeball. This is the positive electrode down here at the bottom. And it's only going to look at the negative electrode. And lead 3, here's our positive electrode again. And you'll notice it's in the same spot as this one over here. They're both the same eyeball, but now it shifts its gaze over here towards that negative electrode. And that's why these are called bipolar leads, because they share the same electrode, but they look at different spots. And then somewhere in the middle of all this is an electrical neutral spot that's called Wilson's central terminus. And I don't know where it is. Maybe it's here. But somewhere in the middle of this, you'll have electrical neutral, where things are not positive nor are they negative. Okay. We just went over all of those things there. And then this is where the little microprocessor kicks in and kind of guesstimates what AVF would look like, AVL, and AVR. The other ones were limb leads. These are precordial leads or chest leads. And this is the one, like I was saying, if you had a hula hoop around the heart with GoPro cameras on it, these are those unipolar leads. What you see is what you get. And the way these are laid out, there's 5 regions of the heart. You have the bottom of the heart, which is called inferior. That's the bottom. Oops. You have the middle of the heart, which is septal. The middle of anything, the middle of your nose, the middle of your brain is considered a septum or septal. Then you have the anterior portion of the heart, the front of your heart. And then you have the lateral side of your heart over here. So you have inferior, that's 1, septal is 2, anterior is 3, lateral is 4, and then the back of the heart's posterior. And the only thing that you cannot see on a 12-lead EKG is the right ventricle over here. Everything else you can view by the 12-lead. You're basically looking at the middle of the heart, the front of the heart, the side of the heart, and the bottom of the heart. You can't see the right ventricle with a 12-lead. The left ventricle is just in the way. And again, that's our heart. This is our right coronary artery, left coronary artery, and left circumflex. So why might it be important for a doctor to be able to analyze electrical activity in different areas of the heart? What do you think? Well, it's in case there's damage. Electricity does not like to flow very well through damage. And then also, if part of the heart is straining, it will pull the electrical activity towards it. All right, so these usually when someone's on a monitor for a long period of time, they're just on a 3-lead, 3 to 5 lead monitor. It's the limb leads, and they're monitoring them for cardiac dysrhythmias, rhythms that are too fast or rhythms that are too slow or disorganized. Same with the Holter monitors, but those patients can actually walk around and kind of live their life. Then for patients that are getting a 12-lead, it's usually at rest. Like we'll have them kind of lay flat and control their breathing. But there's also a group that's going to get a stress test that's recorded while they're, like, say, walking on a treadmill. Electrode placement. Now, if you're just doing, rate and rhythm monitoring, that would be called like a 3-lead monitor. Then you can have the leads up on the torso. That's fine. Normally, the limb leads would be out on the limbs. But if you're just doing rate and rhythm and you're looking for rhythms that are too fast or too slow or disorganized, then that's fine to have them on the torso. And they're color coded, and they have the little initials on there. So, right arm, left leg. When I went through my program, we had to learn where they went. We learned red over rib, white on right, Some people learn smoke over fire for the black being left over. But I remembered white on the right and black is left over the red. That's how I learned it, but I'm sure everyone can probably have their own kind of way to do it. If you add 2 more leads, it's called a 5 lead. That's V1. That's in the 4th intercostal space on the patient's right sternal border. And then you want to put the one for the right leg at the same height as you did for the left leg. So you don't want the right leg all the way down the leg and then the left one up on the ribs up there. Like I said, this is just for rate and rhythm determination. If you're going to do a diagnostic 12 lead, the electrode should be out on the deltoids. That's the right arm, the left arm. And then the right leg, left leg should be down lower than where the leg meets the trunk. So I really don't appreciate this slide because it shows the limb leads up on the torso. And, you know, it depends on the manufacturer's recommendation, but most of them would give you not a very accurate 12 lead. But here we've added our precordial leads. V1 and V2 are looking at the middle of the heart, they're septal. V3 and V4 are looking at the anterior portion of your heart. And V5 and V6 are looking at the side or lateral portion of the left ventricle. These are some more examples of lead placement. You can see the limb leads are normally out on the wrist and down by the ankles, but really we move them up towards the torso because the more they move their arms and legs, the more ectopy or ectopic beats or focus we'll see. It makes funny little waveforms that won't make sense. And then the one on the right is just where they're all the way up on the torso, but the one in the middle is fine for a 12 lead as long as you move that right arm and left arm out on the deltoids, out on the shoulders. And then all of these have colors, but more than I see anything, V1 is red. So you'll see a lot of red, yellow, green, like the stoplights, and then blue and orange. Blue is my favorite color. Then you have orange and purple. Those are the Clemson colors. The more you do it, the more you'll have them memorized. So what are some situations that might require different electrode placements? If they have a condition called dextrocardia, then that means dex is right. So right-sided cardiac, so their heart is flipped and it's in the right side of their chest. Then you'll have to do a right-sided EKG. If you have a person that has like an amputated limb, like a leg, well, you don't want to put one lead way down on a lower leg where the other leg's missing. You want them about the same height. Artifact was the word I was trying to think of. When they're out on the hands and the legs, whenever they move their arms and legs, you get artifact. And the artifact is just distortion or, you know, funky, weird lines that don't make any sense. It masks the actual electrical activity of the heart. Gain control is like volume control. You can turn up the gain to make the waveforms bigger. Most of the time we don't do that. But I have seen it done before. And then a stylus, that we don't have that pre-hospital, but a stylus on your machine, you can actually write, I believe, on the screen and make notes. And then standard gain, 10 millimeters is a standard gain, and 1 millimeter is one tiny block on this paper. And I don't know if they got a strip coming up, but I'll show you what the 10 millimeter deflection is. Let me back it up. They showed that 12 lead earlier. So here on our 12 lead, on the very left of it, there's a 10 millimeter deflection, and that's it right there. So anytime you see that, that tells you that the cardiac monitor is calibrated correctly. So that's a little 10 millimeter, a 10 millimeter deflection that means that we're calibrated and we're in ×1. And that means it's not been zoomed in or zoomed out. So what you see is the actual size of the impulses. Okay, let me see if I can figure out where we were. Here. That's standard gain. All right, so some talking points about placing and powering on the EKG. Get the machine close to the patient. You don't want the cables like when they stick them to the skin, you don't want to like tug on the skin and pull on the skin. You don't want the cables like drooping and being like floppy in between or people bumping into them. Make sure the patient's not like twiddling the cables. That happens because they're nervous. Make the patient as comfortable as possible. The most correct position is them laying flat, but they may not tolerate that if they're symptomatic and having shortness of breath. If you place the machine on the patient's left side, it's ideal because that's the side that the precordial leads are going to be on. So they're not like, hanging off the right side of their chest, lay it drooping across their body. And then you should have the test performed area without electrical outlets because it could have some 60 cycle interference. We're going to make sure that your EKG cables are actually plugged into the machine. And when you attach them, make sure that you're putting the lead wires first. Attach the electrode to the wires first. That way you're not like digging in the patient's skin to try to connect the wires. Some of them you have to like pop on there, snap in place, and it could hurt the patient when you're digging around on there. That EKG paper is basically grid paper. Every little block is a 1 millimeter block, and up and down on the grid paper is millivolts, and left and right is seconds. So milliseconds are, so you're looking at time going from left and right, and it's millimeters per second, sorry. And then you're looking at voltage going up and down. So in this case, on the top there, we have our standard recording time, which is 25 millimeters a second. And on the bottom, they've slowed it down to 50 millimeters a second. So you can slow down the tracing time. Standard is 25, but you can slow it halfway down. And then that just gives you it slows down what you're looking at on the paper so you can tell maybe what some waveforms are. Pre-hospital, we rarely ever change the speed that the printer is printing. So once again, with that gain control, if you have really small impulses, you can turn the gain up so you can get a better view of it. But standard gain is just 10 millimeters. You'll have a 10 millimeter deflection. That's why you got MV next to it for millivolts. So millivolts going up and down, and seconds are going to the right. That's that 10 millimeter deflection. So if you counted all the tiny little blocks for that, looks like a square, then it's going to be 10. And again, that's the gain. Standard gain is 10 millimeters per millivolt. And that's standard. And then you can see down there, they zoomed in to 20 and they zoomed out to 5. So normally we just keep the gain on 10. I'm not saying you won't ever do it, but it's pretty rare. So what type of activity is recorded on EKG tracing? It's the electrical activity of the heart. What mechanical actions correspond with depolarization and repolarization in a normal functioning heart? Well, that would be hopefully the heart pumping, so you'd feel a pulse. But remember, you can have electrical activity without mechanical activity. Why are 12 leads used to view the EKG, the heart? Well, it's because we're trying to get a view of that left ventricle. And what's the purpose of the electrode? The electrode is a piece of just a piece of metal with some conductive gel. And the electrode is what interfaces with the lead cable or the lead wire to give you a lead view. What is the proper way to store electrodes, and what should be done with the inspired ones? Well, listen, the electrodes really should be kept in their foil bag. They come in a foil packet. And if you're not using them, you should close the foil bag and leave them in there. That way they don't dry out. And what should be done when they expire is just get rid of them, because when they dry out, when the conductive gel dries out, you don't you don't have good tracing. So it can lead to a wandering baseline. It looks like these waves or, these undulating waves are going through your strips. So what type of EKG would be ordered for a doctor that wants information on the heart over a long period of time? Well, really it makes a difference on whether the patient is like an inpatient or an outpatient. If it's inpatient, they'll just put them on a 3 or 5 lead monitor. And if they're outpatient, they can order a telepack. So you could do a telepack for that. Or if you're going to walk out of there or leave the hospital, they'll put you on a Holter monitor. What is recorded on the 4th row of the EKG? So the top 3 rows are your 12 lead. The 4th row is the rhythm strip. We usually call it a rate and rhythm strip. That's the 4th row, that bottom 10-second long strip. Which leads makes up Einthoven's triangle? Those are the limb leads 1, 2, and 3. List the electrodes for a 3 lead. 1, 2, and 3. A 5 lead would be when you add V1 and the right leg. And a 12 lead is when you add V2, 3, 4, 5, and 6. Describe the placements of V1 through 6. Well, there's only 3 leads that have anatomical positions, and that's V1, that's the 4th intercostal space, the right sternal border. V2 is the 4th intercostal space, left sternal border. We're going to skip V3 and go mid-clavicular to the 5th intercostal space to place a V4. Halfway between 4 and 2, we place V3 in a straight line. V5 is on the anterior axillary line on that same horizontal plane as V4. And then V6 is on the mid-axillary line, same horizontal plane as V4 and 5. Why should the EKG machine always be plugged in prior to use? Well, you want to make sure the batteries are charged up on it. It would suck if you walked all the way up to the room and then, the thing died, make you look bad and make the hospital look bad. So yeah, we want to make sure it's charged up. 12, what are the 2 paper speed options for an EKG machine? Well, I've seen 25 and I've seen 50. So I'm guessing that's 25 and 50. 25 is your standard speed, and 50 would basically mean the paper spitting out twice as fast. So it would have the effect of making it look like the rhythm slowed down half the speed. 13, why is the paper speed most commonly used? 25. 14, in what cases might a different speed be used? I'll give you a great example. If you have a patient in a narrow complex tachycardia, that rhythm could be AFib, or it could be SVT, and you might not be able to see the P waves, or you might not be able to see whether it's regular or irregular. So if you boost the speed up to 50 millimeters per second, it basically slows down what's recorded for the rhythm, and then you can see whether it's irregular or maybe it slows down enough where you can see P waves. But I'm just telling you, in the real world, that rarely ever happens. Most people don't mess with the speed of it. 15, how can an EKG tech change the height or deflections of the EKG? And that's through gain control. If you have really small, if you have really tiny or small amplitudes, someone might order the gain to be turned up. But once again, I'm telling you, it's very rare that you're going to do that. And that is all we had for this one. Please watch the other video. I think it might get into some medications and stuff towards the end of it, but at least check out the action potential portion of it. And then I'll see you guys on our next class, whatever day that is, like Tuesday. Have a good night.